Framingham Cancer Center at Norwalk Hospital. Who better to talk about colon cancer than someone who has to treat it?
Welcome back to the show. We're glad to have you here. So, colon cancer really is very common, unfortunately, and there's a lot we're starting to know about it, isn't there?
Yes, over the past several years, we've definitely learned more about risk factors and screening and certain prevention.
And it's an equal opportunity cancer too, because it really affects men and women. We all have to worry about that.
Yes, definitely. You have to begin worrying middle age around 50, but definitely men and women about equally affected.
And Andrea, you said at the beginning that we have identified a number of risk factors, and maybe you could start with them. Who needs to be worried about getting colon? We all need to be worried about getting colon cancer, but who needs to be particularly worried, and who needs to even think about screening at an earlier age?
Well, in terms of, everybody should really think about screening at age 50, and it's a good time to talk to your doctor about screening, colonoscopies, or checking your stool for blood. Now, if you have a family history of colon cancer, or if you have a personal history of polyps, then you need to talk to your doctor about earlier screening and possibly having screening more often than the average person.
And I think that's a really important point, because the reverse is not true. That is to say, if you don't have a family history, that doesn't let you off the hook for screening. Some people will think, well, I don't have it in my family, so I don't need to have a colonoscopy. That's unfortunately not true.
Correct. If you have no family history, you still have a risk of colon cancer, but then the age to start screening is age 50.
And there are family histories, and then there are family histories. Right. Which are the family histories that are most significant?
I think the family histories that are most significant is if you have a family member, usually of first degree.
And what does that mean?
First degree would be mother, father, sister, brother, who had colon cancer at a young age. That would be of concern, and that's something, young age is probably less than 50, that you would want to talk to your doctor about, and then your doctor would help determine, number one, whether you need to see a genetic counselor, and number two, what would be the best time to begin your screening colonoscopies.
I know I've heard a rule of thumb is to start, if you've had a first-degree relative who had a young colon cancer, to start 10 years before the age at which that patient or that relative had the colon cancer detected. And
then your doctor can also do a broader history to see if there's other cancers in the family that could sway your doctor to do more genetic testing.
As you mentioned, there are some families that have syndromes with a lot of polyps, and they may need earlier screening. And some other people, like if they've had long-standing inflammatory bowel disease, may need specialized screening recommendations for them, and those folks should definitely talk to their physicians about that.
Absolutely.
And we also know there's some specific genetic abnormalities that predispose people to polyps in some instances, and just colon cancer in other instances. Can you say a few words about that?
Well, I think also just broadly for the population, we should talk just about general risk factors. And I think that's important. I think we do know that diets high in fat and cholesterol can increase your risk of colon cancer. So those are fairly easy lifestyle modifications one can do to potentially lower their risk. And we also know studies have shown that physical exercise is, as little as maybe 3 times a week may lower your risk of colon cancer.
It's pretty remarkable, because we think about exercise and heart disease, but we usually don't think about exercise and cancer.
Yes, and also this will reduce the risk of other cancers as well, and also avoiding obesity. People who are obese can also have an increased risk of colon cancer. So there's a lot of things one can just do with lifestyle changes to lower their risk.
Fiber has been something that's been talked about on and off. Can you say anything about what's the latest thinking about fiber and colon cancer?
I think some of the data with fiber and some of the other, calcium and Celebrex, that data really has been controversial, and it's not clear that that will reduce your risk of colon cancer.
Yeah, I think what you're referring to is there's some data out there, some papers out there that have suggested that aspirin or Celebrex can help prevent polyps, prevent cancer, but people should not be at this point taking an aspirin every day to prevent colon cancer?
No, I think with the general person, the data is not strong that it can prevent colon cancer. There is some data with certain syndromes of polyps, it may be indicated, but not in the average person. It really probably hasn't been proven to prevent colon cancer.
And some people will shy away from going to see a doctor or having a procedure done in some ways because they're afraid of what might be found. But with colon cancer, it's really important, because if you catch something early, often that can be removed and you can be cured, or treated very early and outcomes can be better. Can you tell us about that?
Yes, I think it's very important. I think the data has shown scientifically that usually the colon cancer starts off from a polyp, and it can take as much as 10 years from the polyp to turn into a colon cancer. And a polyp is a very benign growth in the colon. So very often on a routine colonoscopy, your gastroenterologist will find a polyp and remove it, and then the focus of potential cancer has been removed. So I think it's really important to follow the guidelines. In addition, if you do have an early cancer, such as a stage 1, which is just localized and hasn't spread, you have a very high risk of being cured just with surgery alone. So I think the guidelines are really evidence-based and consensus-based, and what the best thing is to prevent colon cancer in the general population.
The polyp colon cancer hypothesis is really relatively new and extraordinarily important in our understanding of this disease. I know now we believe that most colon cancers, if not almost all of them, come from benign polyps at the beginning. Can you say something about that change and how it's affecting diagnosis and treatment?
Well, I think it's
Or should
very...
I say diagnosis and genetic diagnosis?
Yes, I think it's very exciting. At the present time, we do know there's certain genetic changes in the polyp that happen over the course of 5 to 10 years that turn it into a cancer. And researchers are now sort of studying to see if somehow we can even pick up some of these changes in stool samples. So in the future, it might be that we're going to pick up changes in blood test or stool samples, and you may not need a colonoscopy. But the good news is the polyp is definitely a marker that you might be at a slightly increased risk. So when you have your first colonoscopy, your doctor will advise you the findings and then tell you, based on the findings of the first colonoscopy, when you will need to have a repeat one.
So if you have a polyp, you may need to have a colonoscopy again sooner.
Yeah, sometimes if you had a lot of polyps, your doc might say that you need to have it again in 3 to 5 years. And if you have a completely clean one, it might be 5 to 10 years. So it really depends on your personal history and the findings of that initial colonoscopy.
Now, when we're talking about treating colon cancer, maybe you can tell us about what you talk with patients about when they've come to see you as a cancer doctor.
Well, I think the first thing we do is we do a whole history in terms of their family history, genetic history. And then we always sit down with the patient and review their pathology, which is really the tumor sample, because most patients with colon cancer are going to have surgery. And at that point, we review the sample and we determine whether or not they need additional treatment to increase their cure rate.
And maybe you could explain that. I know the idea of micrometastases, I think, are not really clear to people. The surgeon goes in, he or she takes it all out, and they say, it's clean. I've gotten every scrap of cancer that I could see out, and yet they come to you and you say, but I need to give you chemotherapy. Why?
So what happens is when your surgeon does the surgery and sends it to the pathology lab, the pathologist spends a lot of time going through the specimen, pulling out lymph nodes. And typically, 12 to 25 lymph nodes are evaluated for cancer. So sometimes it looked great when coming out and you recover well, but then you come to my office or another oncologist and the lymph nodes may be involved.
In other words, have some tumor
cells in them. And those patients would have a stage 3 colon cancer, and they definitely obtain benefit from chemotherapy, which means the cure rate will be increased with 6 months of chemotherapy.
And statistically, that really means that small tumor cells have broken off and deposited elsewhere in the body, that you can't see them on CAT scan and you can't see them on PET scan or anything else, but we know they're there statistically because of the presence of the cells in the lymph nodes.
And then the goal is that that 6 months of chemotherapy will hopefully kill any cell that's escaped from the colon, and hopefully it would never resurface in your lifetime.
We have about 30 seconds left in the segment, incredibly, and we've talked kind of from screening to treatment. Do you have last words for our viewers from your perspective?
I think the last word is really not to be afraid to talk to your doctor about your screening colonoscopy at age 50 or earlier if you have a family history. And if you have concerns about the procedure, just to share them with your doctor, because there's a lot of different ways it can be done to make it comfortable for you.
That's a perfect segue, because we're going to be talking with a gastroenterologist in the second segment who has some new ways to do colonoscopy that may be more comfortable than some of the old ways.
Well, thank you so
Right.
much for being on the show.
Thanks for inviting me.